Welcome to The Explainer. Today, I am absolutely thrilled to take you on a structured, evidence-based deep dive into diagnosing and managing sinusitis effectively. This is a topic that comes up constantly in practice, yet somehow it remains a persistent area of clinical confusion. Well, we're going to clear up that confusion today. By relying purely on the clinical evidence and guidelines we're about to walk through, we are going to build a rock-solid framework for differentiating a viral from a bacterial etiology. The goal? So you can diagnose with absolute confidence and treat with precision. Let's get into it.
Here is our clinical roadmap for today. First up, defining acute rhinosinusitis. 2, viral versus bacterial etiology. 3, recognizing clinical features. 4, IDSA diagnostics and investigations. And finally, 5, evidence-based treatment pathways.
Section 1, defining acute rhinosinusitis. Okay, let's dive into this by grounding ourselves first and foremost with the strict medical definition, because in this algorithm, precision really matters. So, acute bacterial rhinosinusitis is fundamentally an inflammation of the paranasal sinuses. But here is the catch. The crucial starting point for accurate classification is the exact time frame. We're looking for inflammation that lasts specifically more than 4 weeks, but less than 12 weeks. If a patient doesn't fit within this very specific temporal window, your diagnostic algorithm needs to shift entirely. Time is literally your very first clinical clue.
Section 2, viral versus bacterial etiology. Now that we've got our time frame established, we really must look at the underlying cause. And honestly, this is exactly where the issue of overprescribing usually takes root.
Just take a look at the stark visual contrast here, because it perfectly emphasizes our central thesis for this explainer. Look at that massive 90 to 98% segment. The vast, overwhelming majority of these cases are purely viral. They're simply post-viral inflammation. Now look at that tiny little sliver. True bacterial superinfections account for only 2 to 10% of cases. This visual should permanently reframe how you approach a patient complaining of sinus pressure. The odds are astronomically high that you are dealing with a virus, not a bacteria.
However, when your patient does legitimately fall into that rare 2 to 10% category of a bacterial superinfection, you need to know exactly what you're fighting. The primary culprits making up that bracket are Streptococcus pneumoniae and non-typable Haemophilus influenzae. It's also incredibly important to highlight Moraxilla catarrhalis, specifically when you're evaluating pediatric patients. And finally, always keep a high index of suspicion for anaerobic origins. The data shows these typically stem from underlying dental infections, so keep that in the back of your mind.
Section 3, recognizing clinical features. For this part, I want you to mentally place yourself right there in the clinic and visualize the patient's actual symptoms as they describe them to you. These are the core clinical features your patient will likely present with. You'll see purulent nasal discharge, which could be draining anteriorly out the nose or posteriorly right down the throat. You'll hear about facial pain or heavy pressure, typically localized to the maxillary or frontal regions. They'll describe a feeling of severe nasal obstruction and hyposmia, meaning a reduction in their sense of smell. But listen, here is the absolutely vital takeaway from this section. While these core symptoms are entirely foundational to a sinusitis diagnosis, they absolutely do not automatically confirm a bacterial infection on their own. Remember that massive 90+% viral segment we just looked at? These symptoms overlap heavily with post-viral inflammation.
Moving on to Section 4, IDSA diagnostics and investigations. Now, what's really interesting here is that these criteria serve as the ultimate key to solving our viral versus bacterial mystery once and for all. Let's walk step by step through these 3 highly testable, high-yield criteria that actually signify a true bacterial shift. You've got to look for at least one of these patterns. Number 1, symptoms persisting for greater than 10 days without any sign of clinical improvement. Number 2 is a really fascinating phenomenon called double sickening. This is a classic pattern where a patient actually worsens after an initial period of viral improvement. They start feeling a bit better, and then boom, they suddenly crash again. And number 3, a severe onset. Let's pull out a magnifying glass on that severe onset criteria, because I want to emphasize these specific metrics as an essential clinical pearl for both your daily practice and your board exams. Severe onset is strictly defined as a high fever of 39 degrees Celsius or greater, combined simultaneously with purulent nasal discharge that lasts for 3 or more consecutive days. If you see this exact combination right out of the gate, your suspicion for a bacterial etiology should immediately skyrocket.
So the big question, how do we confirm our suspicions? Well, the guidelines are incredibly clear on investigations. Diagnosis is primarily clinical. You are relying on the criteria we just covered. Crucially, CT and MRI imaging are not routine. You must heavily restrict imaging, reserving it only for suspected complications, invasive fungal concerns, or severely immunocompromised patients. Instead, rely on your physical exam. A targeted nasal endoscopy can be incredibly useful to visually confirm purulence draining directly from the middle meatus. And what about taking a culture? Endoscopic cultures should be strictly reserved for severe presentations, immunocompromised hosts, or cases that are highly refractory to initial treatments.
Section 5, Evidence-Based Treatment Pathways. And this brilliantly illustrates where all of our diagnostic detective work finally pays off. Let's transition to contrasting the distinct management strategies based squarely on the diagnosis we've established.
Let's walk through this side-by-side comparison. For the vast majority of your patients, remember, that's the viral or symptomatic group, treatment is focused entirely on supportive care. This means recommending nasal sealing irrigation, initiating intranasal corticosteroids like fluticasone for duration of 2 weeks or more, and utilizing oral or topical decongestants. But crucially, use those for 5 days or less to avoid rebound congestion. On the other hand, if you have a confirmed bacterial case based on those IDSA criteria, you shift your strategy. You deploy targeted antibiotics, you continue the intranasal corticosteroids to reduce inflammation, and you only escalate to surgery if things become highly complicated.
Let's firmly state the absolute gold standard, first-line pharmacological treatment for those confirmed bacterial cases. It's amoxicillin clavulanate. The high-yield dosage to remember for adults is 875 over 125 milligrams, taken twice daily for a duration of 5 to 7 days. The specific agent and dosage isn't chosen at random, guys. It's explicitly selected because the clavulanate effectively covers beta-lactamase-producing bacteria, protecting the amoxicillin and ensuring eradication of those specific culprits we identified earlier. But, of course, clinical practice is never one size fits all, is it? What do you do if your patient presents with a documented penicillin allergy? Well, the data points us to 2 excellent evidence-based antibiotic alternatives. You can confidently prescribe either doxycycline or levofloxacin to ensure adequate coverage without risking a severe allergic reaction. Lastly, we really must touch on surgical intervention. Functional endoscopic sinus surgery, or FES, is not a frontline tool. It officially leaves the realm of standard treatment and becomes a necessary clinical escalation only when you are faced with dangerous orbital or intracranial complications or in those deeply chronic cases that are completely refractory to all the maximum medical therapies we've discussed so far.
So as we wrap up this explainer, I want to leave you with a final provocative thought to take back to your clinic today. Given that up to 98% of cases are purely viral, are you truly strictly checking all 3 IDSA criteria before you write that antibiotic prescription for sinusitis? It's a vital question for antibiotic stewardship and honestly, for optimal patient care. Thank you so much for joining me on this deep dive. Use this framework to guide your daily practice, stay evidence-based, and I'll catch you on the next explainer.